And we have begun. We've only just begun. All right. We stopped off here, is my recollection, looking at that, the typical oxygen curve that's there. And I mean, this is just demonstrating to you in the relatively short, in the relatively long journey, rather, from in the capillaries within the lung for blood to become reoxygenated by way of the pulmonary system. It takes barely a quarter of a second to accomplish that. So there's a built-in, since the approximate journey is three times that. That's a lot of time, and again, one of these wonderful built-in abilities that the body has to compensate, even if even if the amount of oxygenation and the concentration dwindles. So keep looking at these. You're going to see a few of these that are there, and there are some proper names that honestly, the reason I'm saying about looking up, I have to look up. So I mean, when you see some of the names of some of these laws, I understand. I'd rather not make it an exercise in memorization, more of an exercise in understanding. So this is a big player. Okay, remember the lungs are just it's so many. It's just a unique amount in a relatively small chamber. Think of our thoracic cavity, and you have the heart and a lot of vital structures in the middle. You only have room on either side for the lungs. So even the membrane is only approximately a half to a micron thick. The total surface area of the alveoli is 40 times the amount of skin that you have. That's an amazing number, and it's covered in capillaries. And it gives you an idea of the amount of blood vessels that you have in that area. So, I mean, that's really significant amount. So, and so the effective thickness increases under certain problems. And that's particularly when it gets, if you will, waterlogged. This basically my way of stating to you, and you'll hear me state it in a number of times in the systems we're going to be covered in renal and repro. Ultimately, it can be a plumbing problem. The heart is a pump. If the blood is not pumped efficiently, let's say from the left side, it backs up just the way you'd have a clog in your plumbing system, and it backs up, let's say, into your sink, and all of a sudden it won't go down the drain. So what they're indicating here is that that 3/4 of a second that the red blood cells spend may not be enough for adequate gas exchange, given that kind of situation, given the amount of obstruction there is to the adequacy of oxygen and carbon dioxide moving across. And so that's really significant. And again, the other big factor that is associated with this, and I commented on yesterday, for oxygen to move from the lungs into the capillaries, really one of the two major roles, that is accomplished because of the concentration gradient of approximately 60 or so millimeters of mercury. Again, partial pressures of gases effectively are the equivalent of concentration gradient. Where it's only about 6 millimeters of mercury for carbon dioxide. Why do they move equally? Because carbon dioxide is much more compatible with, much more soluble with the membrane itself. So it isn't only concentration gradient, which surely is the big factor, but that membrane solubility is certainly a significant factor. And then that's really due to molecular shape and size and those kinds of things. So here, when we were looking at what I saw about before, those pulmonary function studies, and that is certainly a nugget on this exam that you'll be seeing on I take that back. This respiratory stuff I'm going to put on the final, not on this Blackboard exam. So one of the things that you will certainly see is about those respiratory studies, the pulmonary function studies, in categorizing these chronic diseases. What they frequently do is reduce the surface area, the ability for the exchange. Remember, that is a restrictive disorder. It restricts the amount of usable membrane. So emphysema would be a perfectly good example. You'll see a brilliant slide in a second about the walls of the adjacent alveoli break down and the chambers enlarge. When the walls become damaged and eventually break down, the air is in there. It may look like there's a lot of air, but the reality is it is trapped. And again, the definition of trapped air, emphysema. Emphysema is not specific to the lungs, as you heard me say several times already. Emphysema just means air is trapped. And so all of these things can block it, whether it's a tumor mechanically, an accumulation of mucus functionally, inflammatory material. So take a look at normal and look at the abundance of surface area in these chambers in a normal lung, only magnified 150 times. That's not a ton. Look at these large chambers and the entrapment that is there. So it doesn't, I mean, obviously, it doesn't take a lot to really, I mean, that's now all of this space because it's all about the surface area here. Without those intricacies of surface area here as compared to here, now you have air that's trapped and effectively non-functional. The lung can't expand, it limits it, so the functional vital capacity is significantly diminished. The very definition of a restrictive disorder. Not so much restricting breathing, restricting the exchange. So here are some of the things we do that don't let us know that that's really what's happening. I do this all the time. And if you haven't figured out by now, I love old movies and things like that. And even more recent movies, I'm constantly looking up. I was sitting there, this sits on my chair when I'm watching. I'm looking up people about them. What else did my wife and I see? And we saw this somewhere else. I'll look. And I'm curious to see if they're still alive or not. And frequently the ones that have died from the era of when many of these are made were all smokers. Famous people who smoke constantly. Famous athletes who smoked constantly. Surprises you. So all of those types of things, this is where that comes into play. Perfusion, an important name. I said before, it's not just the blood flow reaching the alveoli. Perfusion just means adequacy in blood flow for whatever the task is and whatever the organism. So if we call it ventilation perfusion coupling, we're talking specifically about marrying the amount of air to the amount of blood supply. And they do this, and this is one of those neat ways that it, how should I say it, avoids some of those areas that you just saw previously where it's trapped. They must be matched optimally. Both are controlled by local auto-regulatory mechanisms. And in the next chapters that we do on the kidney, after digestive, you'll see some of this. In the kidney, you'll see a ton of this. Okay, so the PO2 controls perfusion by changing the arteriolar diameter. So what is it doing? It's bringing those arterioles and widening them when there's available oxygen. The PCO2 controls ventilation by changing the bronchiolar diameter. So we have two factors, the amount of waste product and the amount of oxygen, that are effectively making a marriage of widening the vessels and directing the flow to in such a way and controlling the bronchiolar diameters. Again, these are structures that the smooth muscle can open and close efficiently to marry to one another. That's why I keep telling you those examples. All of a sudden, oh my God, I had a rough night lately. Well, now you better be on oxygen for the duration. It's horrible because your life is now irreversibly altered. Again, a path undoubtedly I was heading on. So here's the influence locally. So the oxygen in the alveoli cause change in the diameter of the arterioles. Where it's high, they dilate. Where it's low, they constrict. So it directs blood to go where the oxygen is high, so the blood can pick it up. Opposite mechanism seen in systemic arterioles that dilate when oxygen is low and constrict when high. Okay. So again, pulmonary arterioles are more about receiving the oxygen. Okay. And even though in the systemic area, we're trying, as you can see, it's all about oxygen delivery. If there's an insufficient amount, then why don't we just dilate those to try to optimize it? So it's, again, the distinguishing factors between the systemic and the pulmonary circulation. I'm telling you this for the sake of completeness. I try not to go crazy with that language. It can be very, very confusing. If you end up going into a field that involves a lot of respiratory, this becomes much more relevant. I understand because that's easy. If you miss like a word, then it makes all that the question answering. And I mean, for those of you going on to take licensure exams, those are systemic, pulmonary, all of those dilating, constrictive. Those are really significant words and kind of point you on the path. So, what are the influencing factors? As you can see, local PCO2 on perfusion. Those changes in the pressure of carbon dioxide, changes in diameter of the bronchioles, what they said, where there's a lot of CO2, they dilate the bronchioles, CO2 is loose, they constrict. Because we want to get rid of the CO2. It's fairly straightforward. That one's easy to understand. Waste products, maximize getting rid of. And so all of these result in balancing of ventilation and perfusion. So the arteriolar changes, the bronchiolar changes. It's never balanced entirely because it's very regional and there's different things. It can be gravity. And we get this all the time. We'll get areas where we have, like I have had this morning, I took a second allergy pill. Go figure. But every so often you get a day like this. So we had, as I'm sure you all noticed, a rather large temperature change from Saturday to Sunday. All of a sudden, we're out in the deck sunning at almost 80 degrees, and the next morning it's like, what the heck? As I said, it was FF, and the second word is freezing. And it's all right. You haven't changed that much. You never laugh at any of my jokes. I'm showing you some neat pictures of this, which I refuse to go over. That is pulmonary respiration. The word I use for that is breathing. I know it's a complex universe. Here's internal respiration. I would call this cellular, just to be clear. So we're really doing something similar to this at the capillary level. So partial pressures and diffusion gradients are reversed. So the PO2 is lower than the arterial blood, 100 to 40. Remember, it's roughly the same before. So the oxygen moves from the blood to the tissues. Got that? Okay, CO2 is always higher. Okay, 45 to 40. So CO2 moves from the tissues into the blood. So it will get to the lung and be gotten rid of. So venous blood has a returning PO2 of 40 and a PCO2 of 45. And those were the numbers that you saw before, more or less. It was either 46 to 40 for CO2 outgoing, 106 for, from the lungs going into roughly 40 incoming. And again, they show you the picture with all the things that are there. And if these are helpful, fine. Utilize those. But they're just trying to give you a difference between what happens, let's say, at the tissue level and what happens at the level of the lung. That's what they're trying to demonstrate with that particular diagram. Don't necessarily love it. And that is, we're not done yet. That's just this one. And this will just show it to you in a bit more detail. These are the names. There's a Haldane effect and a Bohr effect. To me, they're pretty similar. Okay, with these kinds of things that are there. So the one I think is, that's one of those, like the names I'd look up. For some of you, if you're going on, particularly to medicine or higher level of graduate with medical, you'll find, it's always been my experience, and it was, people are crazy for these stupid names. They love them on exams. They love to fire questions at you. I mean, for anybody, if you're going into medical or dental or vet, students in years above you are just firing you questions all the time. It's like a little game we play. Okay, I know it's a learning game. It can be very annoying. But unfortunately, you learn in life with a lot of things you just got to put up with. So, nevertheless, the Haldane effect. The amount of carbon dioxide transported is affected by the oxygen. I'll buy that. The lower the oxygen and hemoglobin saturation, the more CO2. Okay. That reduced hemoglobin buffers hydrogen and forms carbaminohydrate more easily. So effectively what this is about is encouraging CO2 exchange at the tissues and at the lungs. As the tissues, as more CO2 enters the blood, more oxygen disassociates. So the how then, I looked it up, if you even like AI it, okay, look at the similar, they're really describing basically the same coin. So at the tissue level, as more CO2 enters the blood, more oxygen disassociates. They call that the Bohr effect. Okay. So, I mean, if you want to say one or the other, and I really don't view them as, I view them as pretty much similar. So the oxygenated hemoglobin releases oxygen. It more readily forms bonds with CO2. That's kind of what this is all about. Okay. So as you can see, even at lower oxygen, the CO2 is more easily carried. So as it stands to reason, as oxygen is released, the CO2 is more easily brought in to the party to form that carbon hemoglobin. They say the same thing. I mean, again, I think the names are more confusing. So what's so significant about this? Again, we see it a number of times. This is just another one. That carbonic acid buffering system. And even though we're having that influence of CO2 either in the bloodstream or not, all of it does without this buffer, it would cause dramatic ulcerations. If you put more water in CO2 without that buffering system, you're going to increase acidity. Again, the carbonic acid, H2CO3, is by definition a weak acid, and weak acids make good buffers because the word I like to describe is they're ambivalent about hydrogen ions. I'll donate a hydrogen ion or I'll keep it. You can have it. No, I'll take it back. That's a buffer. Okay. The ultimate fencer. My wife would describe me as a buffer. She recently has informed me that I have did I tell you, a phlegmatic personality? I thought it means this guy coughed up a lot of stuff, but no, this is not the case. I'm inherently non-confrontational. I can see your point of view in the back of my mind. Go, no, you're fucking. But I digress. I'm more or less non-confrontational. It's okay. She, on the other hand, is not. If you don't listen to me, I'm going to throw a shoe at you. That was this weekend. I'm just hoping it's a soft shoe like a slipper. So here's the system. We already knew about this. It helps blood. If the hydrogen ion concentration rises, it'll combine with bicarb, form more of H2CO3. It'll disassociate. We can blow it off in the lungs. So if the concentration begins to drop, okay, we can release the hydrogen, fine. And so the alkaline reserve is something that we see. That's the amount of bicarbonate ion that is present with regard to this system. So we see this. And this is what happened. The changes in respiratory rate and the depth affect blood pH. So we see this before. If you're doing very slow, shallow breathing, an increase in CO2 in the blood resulting in a drop in pH. You're not blowing off a lot of carbon dioxide. And the opposite, rapid deep freezing, we're blowing off a lot of carbon dioxide, and we can adjust it accordingly. We do it all the time in exercise, all of those times that are there. And so we can adjust pH by metabolic factors. And really that's the classic example is exercise or activity. It may play a role. You can see it in metabolic disease. One of the classic ones that we see is with diabetics. They become acidotic. So what they try to do to compensate is they tend to have, it's a fancy name, it's called Kussmaul, capital K, I believe it's spelled capital Kuss dash capital MAUL breathing. And so you get these rather, and it's a very foul breath. It's like acetone breath because you have a lot of ketones in acidotic breath that are there. So it's kind of like they're very often, I may have told you, because they don't have a particularly good gait because of neuropathy for being drunk. It'll be like, well, I didn't drink at all. Well, you're going in and it'll look like public drunkenness. And then They get very embarrassed when a blood sugar test come back in over 300, and they go, "I told you I was a diabetic." That's a false arrest. I mean, it's ultimately it's we're too easy to look at things and make snap decisions. So I think that's important. What are the causes of hypoxia? And what happens when you don't have enough oxygen? You might remember a while ago, we look at color. When someone is jaundiced or yellow, we think about the liver. When someone has redness, we think about inflammation. Okay. Carbon monoxide poisoning is characterized by a distinct pinkish hue. Interestingly enough, it's not so much red, it's a very distinct, it's one of those diagnostic things that the emergency, like EMTs, when they go into a house, that's a big tell right away. When doors are shut and then all of a sudden somebody on the ground with first of all, it's unlikely they're going to recover, but it tells them, watch out. I mean, go back out the door and get some kind of protective equipment because this house is filled with carbon monoxide. Okay. So there are different tells that are there. But what causes this results in, with inadequate oxygen, you get cyanosis, indicates an abundance of unoxygenated or deoxygenated, relatively speaking, blood. Okay. And you'll see it's like a dusky color in the lips, fingernails, toenails, under those areas, which really reflect it. And unfortunately, it's a poor. So for those of you who are watching The Pit, it gives you an idea. There's a lot. Whoever does the technical advice, it's all about this stuff. When we see someone who's cyanotic, that's at least back in my day and age in emergency room, that was a bad thing. You saw someone cyanotic, they're in trouble. You better get busy on them because they're not going to make it. Okay. Well, we had a lot of people who were sick people coming in. But those are all those little tells they look for. So, anemic hypoxia, not enough red blood cells, or abnormal or too little hemoglobin. That's what I had. Because I had a bleeding disorder internally. I had anemia. And my color was awful. Just awful. That was before we all had digital cameras and phones and smartphones. So I don't have any pictures to show you, nor would I want to necessarily show it to you. Ischemic. Circulation is blocked. For many of you who go into clinical fields, and it doesn't have to be clinical, it's so easy to tell if you know. You typically see them in the extremities more than anywhere else. And so what you would do, you want to check temperature of the skin changes. The farther you get away from the heart, it changes. So it should be, the skin temperature should be warmer here than here. And the way you test it is not like this. You test it with the back of your hand. There's too much circulation in the palm of your hand. And therefore, we use the back of the hand as a very good model. And you look for particularly, not gradual, you really look for a sharp transition line. The sharper the transition, the more likely there is a blockage that you will see. So when you all of a sudden it goes warm, you don't see, the word we use is gradient. So when you don't see an acute gradient, you see a very sharp gradient. It's like, oh, trouble. So these things, because you all have, hopefully, older relatives who are getting to the stage where they might be older than I am. Unlikely as that might be. Thank you for smiling in the front. Thank you. Mariah would smile, but she has something important to do. Let me see, go to my lecture or have to take care of a sick cat. The cat wins every time. How are you? And then histotoxic. Histo means tissue, so something that's tissue toxic. Okay. Basically, these are poisons. This is how cyanide works. It works on a structure that you're familiar with, cell and molecular. A particular pathway that involves hydrogen ions moving from one side of a mitochondrial membrane to another. We refer to that as You're in a mitochondria and you're moving hydrogens around. What's moving the hydrogens to one side of the membrane? Yeah, the gradient's bringing them back over. I agree. Good answer. How do they get there? The pump is where they generate the ATP. How does the hydrogen get there? It involves a chain. Hint. Gee, you got it on the first try after 16 hints. Yes, they usually impact all those wonderful metabolic poisons like cyanide. Okay, interfere with that very, very rapidly. Hypoxemic, classic. That's really what we talk about a lot of respiratory is the difficulty when we don't have enough oxygen in the air because of normal ventilation, or we're in areas where they're like going at altitude. And this talks a little bit about altitude. And then here's the biggie: carbon monoxide poisoning. Carbon monoxide structurally, okay, the distinction between CO and OO, okay, the bonding pattern, I'm not sure if it's a double or triple bond in the carbon, but effectively the double bond of oxygen is, molecularly speaking, this is a much more secure favorite attachment. As you can see, 200 times greater affinity. That means it holds on to it. And I mentioned this before when we start talking about hyperbaric chambers. The trouble is, once they have the carbon monoxide poisoning and you see that tell of pinkish hue and hope if the person is still alive, you have to get them on high concentration oxygen, and particularly if you're going to keep them alive, like a firefighter, let's say, in one of these chambers. And really that's, and there aren't a ton of places that would have them. The places would have them would be a burn unit. Where are the burn units in Pittsburgh? What hospitals? There are two. Not that you all necessarily going to live here. One is at Mercy Hospital. That's probably why UPMC bought Mercy, which was independent, well, this many years ago. And the other one, since that's a UPMC, would have to be an AGH. And that has been the one that's been around the longest. That is at West Penn, over in Bloomfield. West Penn, Bloomfield. Liberty Avenue. It's okay. That'd be nice. The problem with that is burn patients are really multifactorial to treat. You're treating the problems associated with smoke inhalation. You're treating the problems attendant to burns, skin coverage, and infection, and respiration, because a lot of times the smoke and the burns have obstructed the passageway. They can't breathe very well, and they can't ingest food very well. So you have to know a lot about TPN, total parenteral nutrition. In the old days, we said being fed intravenously. It's a very complex management problem. And they had a really good team here that did this. I was more familiar with the West Penn doctors. I didn't know the Mercy doctors very well, but I knew the West Penn doctors back in the day. And so that's the thing with regard to that. I don't know if there's anything with this. I really don't know. I haven't tried that flick. Let's see. I don't know if it plays on this system professionally. I don't think so. We had trouble with it before. I can play it directly, but I think I'll hold off. If I can get to play, I'll send it to you. How's that? Rather than worry about it not being, for whatever reason, there's some setting doesn't have it enabled here. Okay, these are fairly straightforward. The rhythms of respiration, most of them are strictly controlled. That's what I meant before. It's that, like, and I always use that kind of the little thing, I'll fix you. I'll hold like the little kid throwing a tantrum. I'm going to hold my breath till I die. Well, go knock yourself out because you're going to collapse from lack of oxygen. And then these sensors will kick in. You can't do that. The only way you can basically is induce that is by something that depresses respiration. Classically, there are certain medications that do that. From an illegal substances perspective, narcotics are part of that. The cause of death from narcotic analgesics excessively, whether it is a ton of Vicodin, whether it's morphine, whether you're injecting heroin, is respiratory depression. Okay? That's the big problem that we have with those. So when when they use like Narcan and they have that available to be able to block those receptors, that's only half the battle. At that point, you have to do something to support, to either stimulate respiration or support respiration or artificially get respiration going, like with a respirator. That's the only part of it. We in the emergency room, that was in its infancy. We had the Narcan, it was not commercially available to people. So if we could identify that, I mean, it's a lot of ODs out there and more today with the remarkable availability. A little pharmacological history. For some reason, some stupid research was done about the fact that opiates, particularly taken orally, were not nearly as addictive as people thought. Nothing was farther from the truth. Nothing was stupider than that. And we had an age where people were taking extraordinarily large amounts. This is where we started to see OxyContins being made. And they were giving a pill that had not a typical Percocet taken orally, 5 milligrams of oxycodone. This had like 50, 80 milligrams. It was in a tablet form. Ostensibly, it wasn't going to produce addiction. What they did, we used to call it hillbilly heroin. They would take that pill, smash it, and snort it. And you're getting a potentially lethal dose. That way, you'd smash it and you'd snort it, or you'd smash it and you'd cook it and inject it. Massively high doses were being given. And people were becoming addicted. We knew about this. I don't know how this was in the 80s, such a dramatically large problem in the early 90s. It's just, now there's much, much greater controls about this that are there. For some reason, it escaped the scrutiny that we have. We had scrutiny before and we had scrutiny later, but somehow the scrutiny in the middle just wasn't what it was supposed to be. Okay, nevertheless, these are the control centers. Here are a ventral and a dorsal respiratory group in the medulla. And effectively, they generate a rhythm. So it's kind of like if you're a kid and you had piano lessons or music lessons, they had a metronome, that deal. I only saw them because I have my musical talent you're seeing now. It's right with my artistic talent. And so it sets your rate, which is most of us is 12 to 15. And so we call that eupnea. So when someone is eupnic, they're respirating fine. You don't want it greater or lower. And basically they excite the inspiratory nerves, which are the only active part of breathing, again, normally is inspiration. We're taking a breath. We are affecting our external intercostals and the diaphragm. Those are your main muscles. When you expiration, that action is merely relaxing and it requires no energy. Okay. But if you're inspiring, if you're taking a deep breath, if you're doing a forcible exhale, all of those kinds of things require energy. But normally, the only one that doesn't is with routinely expiration. That's there. And it's not necessarily clear. And there's also mechanisms in the pons that has influencing on it. And basically, it's about making the transition between inspiration and expiration pretty consistent. So when people have, and this is the problem I talked about ages ago, we talked about the central nervous system and we talked about the brainstem. The brainstem is basically the major portions are the pons and the medulla, the midbrain, to a lesser extent. Tumors there, damage there, strokes there, bad prognosis because they're going to affect vital functions. That's the problem. So prolonged periods of apneustic breathing. And when we see that, eventually it's going to lend itself. It's going to be turned into something that's going to be no breathing that are there. And they show you where the locations in the pons and the medulla are that are there. And that's the most I want to say about them. So it's not understood. Pacemaker neurons, probably. Intrinsic rhythmicity, probably. Okay, reciprocal inhibition. Okay, and so when one's firing, the other relaxes. When the other one's firing, the first one relaxes. That's reciprocal inhibition. That's there. And then the greater the stimulation, the greater the depth. And so all of these are modified by changing demands. We don't really notice them until you're thinking about it. So what happens? You go out for a run or you have to do something vigorous, and all of a sudden you're like, boy, and you didn't know that you were just catching your breath, but you're catching your breath. Or you don't know what's happening if you had a monitor on and measured your breathing when you were sleeping, you would notice a marked change in the frequency of breathing and the depth of breathing because you don't require as much oxygen. It kind of makes sense, I think. So we move on. The important chemical factors. Number one on the hit parade, the single most important chemical in breathing, CO2 levels. They impact pH, and then it gets a little bit different. So it's in this batting order. CO2 first. Oxygen and pH considerably less so. And these are maintained by chemoreceptors, both centrally and peripherally. The brain central. So you remember when we looked at pressure sensors previously in circulation, we talked about the carotid and aortic sinuses. In the same location are chemical receptors, the carotid and aortic bodies. Bodies are chemoreceptors, sinuses are pressure receptors. Their job is similar in that regard. So what happens, and we look at the influence of CO2, most potent and most closely controlled. Why it is this way all has to do with carbonic acid and its ability to release things. We do not have carbonic anhydrase is an enzyme that is found in the bloodstream, in the plasma. It is not found in cerebrospinal fluid. That is the most significant feature. Because of that, it limits the reversibility of the carbonic anhydrase, the carbonic acid buffer. So CO2 accumulating without carbonic anhydrase in the cerebrospinal fluid triggers that breathing. That's the one where I'm going to hold my breath. You're going to collapse, but the carbonic acid buffer is not going to allow that buffering to occur to any of the same degree. That carbon dioxide buildup is going to immediately trigger the need to commence breathing. So in blood PCO2 levels rise, CO2 accumulates in the brain, joins water to become carbonic acid. It just doesn't have that neat reversibility of the buffering system that's there. The carbonic acid does disassociate to some, okay, as you can see here. And what happens, and it's going to do the proper thing if it can. The increased amount of hydrogen ions, central chemoreceptors, synapse with respiratory regulators. The respiratory centers increase the depth and rate, which act to lower it. But you're going to be unable, it's not something that you can deal with effectively. So with people who are divers, particularly free divers, it's pretty standard stuff. My wife texted me. That's good. She loves something that I texted. So I'm in good shape when I get home. I'm in the no shoe zone. This is a good zone. All right, moving on. So, in a free dive, what do they do? Anybody do free dives for depth or try to hold your breath underwater? You do 3 cleansing breaths. You blow out as much CO2 as you can times 3. Take the deepest breath you can and do your free dive. So, I mean, I teach you as kids so you can hold their breath the longest underwater. Same deal. I mean, as kids, you can do it a lot better than you can as adults. You just can't. Okay. You're not as intimidated about the process, I guess. But we had a good time doing that. We were in the pool, you had the ladder, you try to get over there so you could brace yourself against the ladder. We all did this. So that's part of it. So the CO2 you're trying to purge it. That's why the importance that's there. Okay, if blood PaCO2 levels decrease, respiration becomes slow and shallow. And so cessation that may occur when the CO2 levels drop abnormally low. So this is the voluntary hyperventilation to hold their breath longer. Okay. So that drop in PCO2, which causes a delay in respiration as PCO2 levels need to build back up. I mean, it's not necessarily, it's fraught with dangers, okay, because of the drops in PO2. So it's nothing I'm telling you to recommend other than for interest. I mean, I never pursued that. Like I said, my first wife was a certified scuba diver. That was really an interest of her. And she was great with our kids all could swim like fish. I just, it's just, all that, the swim lessons and stuff like that, they were all really good swimmers. And so I don't know that I don't get as much out of that as I do, but it's trying to show you the different things that are there. Okay. All the different things that are influencing what the stimuli are, what the results are, the whole idea of returning things to normal. I don't get a lot out of that, but that's fine. I'm not gonna, again, stuff I don't ask about. But this is the problem with hyperventilation, and we typically see that with anxiety attacks. If you haven't, I mean, when you see a panic attack in somebody and people are, oh, that's scary. Have you ever seen one of those? Where somebody goes full blown panic attack? Oh my gosh. So you're trying, I mean, then they're hyperventilating. That's the whole breathe into the paper bag thing because they're pushing out so much CO2. They're becoming the opposite. They're becoming alkalotic. Retaining CO2, you become acidotic. And all the things that are there, dizziness, fainting, these types of things. So you're rebreathing that CO2. So something that inherently increases the amount of CO2 that's there. I have seen a couple of things like that. Sometimes there's an underlying one. I don't know what brought it on. My middle one, and I was a little dismissive of that. He goes, Dad, I'm in the car. I was on his way to work. And before he got in the car, he's like, I don't know why. And it turned out he was just so difficult. They actually did a workup. And remember, I told you a little bit about this. Remember when we did the anatomy of the heart, that patent foramen ovale, that sort of hole between the atrial chambers that were there, that Chris Letang has, that they have had fixed. And I mean, they did a workup on him. It looked like he had one. I don't know that they ever proved it, but whether or not that might have been the trigger, I do not know. When they followed it up, they said that there was not enough evidence to suggest that he needed to have any kind of procedure, but it was something that they were going to observe. So whether or not there was one little trigger where maybe something occurred there that started a mini event, I don't know. But it was scary. So, it just didn't overnight up in He was living in Monroeville, then up at Forbes Medical Center there. And that was fine. It worked out. So now the other influences, oxygen. In the aortic and carotid bodies, again, oxygen levels, normally only a slight effect. If you're relying on oxygen levels, that is not good because most of the oxygen is bound to hemoglobin. That's what we're going to look at again ever so shortly, that hemoglobin curve. When your venous blood, you have four. Every time we look at a molecule, every time we look at hemoglobin, right, with the two alpha and the two beta chains, we have four heme units. They basically can hold four molecules of oxygen. And even venous blood has three of the four. It's your oxygen reserve. So we don't have to, it's really, we don't have to look at that. That's why it's so, relatively speaking, not an important measure. They're showing you where the carotid bodies and the aortic bodies are classically associated in what they tell you. The pH is significant. Anything that increases acidity, okay, this is carbon dioxide retention, will be acidity. Lactic acid associated with exercise or some kind of misuse. Ketone bodies, particularly in diabetics. And so, again, you're going to try. That's what I meant when showing that sort of abnormal breathing in a diabetic. This would be a classic example of it. Kussmaul breathing, which we're not doing diabetology here. So the most common stimulant, rising CO2 levels, oxygen indirectly. If oxygen falls below 60, it becomes a major stimulus. If PO2 falls below 60, you are in big trouble. Anybody you know. That curve that are there. And there's a lot of different controls that are there. Hypothamically, the limbic system, remember that's emotional. Okay. This is the kind of things that we begin to see, particularly that anger, pain, and trying to get people to breathe when they're in shock or angry or hurting. You're trying to remember, you keep saying that to people like that in your orbit, even if you're not in a medical field, slow, deep breaths. It's important to breathe. And you need a lot of, your tone is so important when you speak to people. So it's something you develop. You'll see, sometimes you have to use a harsh, striking tone, but most of the time I found that using more of a soft, conciliatory tone is better. And then the irritants that are there, fumes, we're all familiar with that. These are the stretch receptors that are involved. A lot of times as it expands, so inhibitory signals to the medulla to end inhalation and allow expiration. This is Herring-Brewer reflex, or Herring-Brower, depending on who pronounces it. So it's more protective so people can't overly inflate unless they're really forcing it to do so. It ends normal inflation. And thankfully, this brings us to the last portion of respiration. More than anything else, what can go wrong? So the opposite of apnea, if you hear someone is apneic, they're not breathing or hardly breathing at all, versus hyperpnea, breathing excessively rapidly. As you can see, by adjusting our breathing, we can maintain the appropriate levels of CO2, O2, and pH. So these are the kinds of things that happen in exercise. So whether this has been well studied. So with me, so somebody like me is going to drive over to Planet Fitness near my house. Just the very fact that I'm getting there, as soon as I get out of the car, things are starting to change. And then first psychologically, then the start of activities, then excitatory to these different areas. And all of these changes occur just by the idea of the anticipation and the beginning of exercise. Okay. And then the factors begin to change. And so it's really interesting that, I mean, these are the kinds of things that exercise helps to build up. You begin to, your respiratory function improves, you improve your cardiac output, the skeletal muscles are more able to uptake it for longer periods of time. That's the idea. Look, guys, I've told you that. I mean, for me, it's maybe for you, it's working the weights, you're working the machines, or looking at, I'll be doing a leg day today or an arm day today, and that type of stuff. For me, it's get the cardio and then we'll work on it. Then it's usually do some crunches because I have a that rounded area in front. My wife is overly critical of at times. Again, opportunity to smile or laugh. Yet not, just saw another post about this. It's coming. They'll stay alive. Spaceballs too. A search for more money. Altitude. Very significant. We adjust over time. Time is not a couple of days. Time is a couple of weeks or a month. Okay. Mountain sickness. I had it. It's awful. The thing is, very often when you travel quickly, when you get on the plane here and get off the plane in Denver, which I did, and where we spent, I felt it the next morning. We stayed a day in Denver, stayed in a motel, my wife and I. I'm having breakfast. I'm like, boy, I really feel a headache coming on. We got in the car. I couldn't drive in the car we rented. We were taking my daughter, my stepdaughter, her boyfriend, another friend of hers, and my stepson. So there were six of us going. This was during the lockdown. They all had to wear masks. Colorado was very restrictive until we got into our room. That was there. And what happened, I'm like going crazy. We went up to almost 11,000 feet until we finally settled out at about 8,000. We stayed up at Snowshoe. This is during the summer. So it wasn't about, it's just a getaway from that period of time. There's nothing wrong with it, with the trip. But I mean, I had 24 hours of the worst headache ever for me. And a lot of people have had it. So I had a minor episode about that. And my stepson had that even from just driving there. He had to stop for a couple of days. It's just, the transition was fairly abrupt. Even in a car, sometimes we flew. So I had all of these types of things. And sometimes you really have to address it. Fortunately not. You acclimatize to this relatively expeditiously that are there. I'll probably go for 15 or 20 minutes and we'll be done. Can you hold it? Are you good? You'll be done with me for today. So what happens, the long term is much easier. They become more responsive when oxygen declines, and there's more adjustments that are made, tiny changes in minute ventilation that stabilize. It's typical, like for sport, they used to think, oh, we'll go out to play the Broncos, but it didn't work. That was the classic where Ryan Clark for this ended. I told you that story. He had sickle cell trait at low altitude. He sickled. He lost his spleen. He lost his gallbladder. He was in big trouble, and and obviously they would never let him play again. And the Steelers to this day have never won another playoff game in Denver. Where they won in Denver to go to the Super Bowl the year that the first Ben Roethlisberger Super Bowl. That was before Clark came. That was there. So I mean, this is really so. It takes soccer teams know this. For the World Cup, they're going to have some in Mexico. They're going to be at altitude. They are going to come early. They'll be on that plane from a lot of those countries at least a month, if not 6 weeks before. That is routinely done for World Cup preparation. And the adaptations, you're going to increase the number of, you're going to hemoconcentrate, you're going to increase the number of red cells appropriately. Okay. So high altitude, lower than normal due to the availability of the oxygen. We stimulate the kidneys, accelerates erythropoietin, it increases long-term compensation. That's the classic example to be familiar with. This is what you don't want to be familiar with if you can avoid it. COPD and emphysema. These are the ones that we talked about vis-a-vis those pulmonary function studies. So chronic emphysema and chronic bronchitis are both part of that. Chronic emphysema also plays a role in trapped air. Emphysema is sort of the overlier of both, I believe. So the key feature is the ability is, in this case, when it's obstructive, there's something in the way. We can't force air out of our lungs. That's that FEV1 decreases. Common denominator, here's a surprise. You may wonder why I don't demonstrate the test. I'm afraid to look. I mean, really, I don't have emphysema, God bless. I'm very fortunate not to be in that boat. Very fortunate. So all of those types of things, coughing and frequent infections, very fortunate for all of those things that are there. Emphysema is part of it because of the alveoli and those walls that you saw in that brilliant slide that they had. The elasticity decreases. You have to use your accessory muscles. Breathing isn't effortless. People have to use shoulder muscles and back muscles to be able to breathe. Okay. And what happens, you end up flattening the diaphragm and expanding the chest. And then you're already in an inspiratory position. So it's like with muscles. You already have started to limit the availability, the amount of expansion that you could have. You're already in an expanded position. Okay. And then it makes it harder and it puts more stress on the right ventricle. The air, it's harder to get the blood in for exchange. And there's other factors that are involved. I'm not familiar with that alpha-1 antitrypsin. My guess is if that was a factor, I was fortunate probably don't have it. I'm able to do those things a lot better. That's what I mean. I concentrate on that. I breathe very noticeably, intentionally when I'm on the treadmill, in between me singing. Which I hope nobody hears, but I've got my earplugs in, so how could I tell? I'm that guy you don't want to be next to on the treadmill. Katy Perry, I kissed a girl. I think there are good songs for that. So chronic bronchitis, I had plenty of this. Irritants, smoke, inflamed and fibrous, obstructions, frequent pulmonary infections, smoking, environmental pollutants, which are smoke by definition, but we have a lot of them around here. So, and these are the two types that we see. I would have been a blue bloater. Patients usually stocky, no cracks. I like to consider it being sturdily constructed in a non-vertical manner. So cyanosis is due to hypoxia, bluish color. Pink puffers, thin, and it's difficult. And the gases, you're burning a lot of energy, so they're puffing. So they look like normal skin color, but in the reality is their vital capacity is diminished. It's hard for them to get it out. So I would have been in that category. And I think I told you, when I was a resident, a heavy smoker, this guy was already a legend at the hospital, a legend in Philadelphia radiology. We're doing routine chest x-rays. He goes, let's look at yours. Everybody was down there. He looked at mine. He looked at me. You're a smoker. He goes, you're going to get emphysema if you don't stop. And it took me only another 30 years to stop. So those are all the things that are part of it. They show you this in the graph, all the things that can cause it. Asthma. So it is a kind of COPD, but it's acute because of all the things that go on. We're familiar, we all know somebody who has asthma, somebody who has a ventilator, somebody who might be prone, unfortunately, to anaphylactic shock. All of those are part of it. So it's always an inflammatory process. bronchospasm, we talked about it, immunological, the IgE, inflammatory cells, interleukins, and and then more of that, the inflammatory exudate, which is part of that chemical, which triggers those things, will even magnify the effects that are there. We didn't do tuberculosis. It's too long for me to do here. I'm telling my micro classes now, there has been a big increase. This is considered a resurgent disease, meaning we almost had it licked with TB testing, chest x-rays to confirm or deny, and then treatment when necessary. Magic. But in the advent of HIV/AIDS, so we're seeing immunological disorders that were affecting people. This is a disorder that is part of your immune system. An AIDS defining diagnosis is someone who's HIV positive, he has tuberculosis. At that point, they now have AIDS, period, which means they're going to die sooner than they should die. It's called an AIDS defining diagnosis. So it's something that people get typically if they are not immunosuppressed from overcrowding. And we're seeing a tremendous increase in numbers over the last 3 years, particularly in urban environments. The people who are living deep in the inner city, impoverished, homeless, all of the above, we're seeing a real uptick in this, and scary. If it becomes, there's a lot of people have it latently. I'm not going to go into the whole thing, but it's easy if they're latent and their immune system is not good to start with, and they have other risk factors, whether they smoke, whether they drink, whether they're homeless, whether they don't have good medical care, whether they have some underlying disease, they will convert to active, and then they have to be treated. If they're not treated, then it goes into probably something that's going to close their life down sooner than you think. Big thing to know when they're in late stages, night sweats. Same thing with cancer patients. Their body's being gobbled up from the inside. The best way to understand tuberculosis when it spreads, it's a bacterial infection that acts like cancer. Starts in your lungs, gets into your bloodstream when the things in your lung burst, and they can go anywhere. Bone, lung, heart, kidney, name one. So just like cancer spreading, a metastatic tumor, miliary or spreading tuberculosis, miliary for seeding all over the body is one of the things that's like this. Long course of antibiotics, you have to use multiple different antibiotics, change them out all the time because it develops resistance so quickly. The big thing is night sweats and coughing up. It's interesting. In pneumonia, we look at the color of the mucus, the phlegm that you bring up. If it's rusty brown, is it frankly red? Is it somewhere in between? It tells you what kind of pneumonia. In tuberculosis, it's almost like, because it's damaging the lung, it's almost like actual blood. It hasn't undergone really any, and so it's almost like a swirl of mucus and blood. Very distinctive when you see that. It's a very, very bad sign. And lastly, and certainly not leastly, the leading cause of cancer deaths in North America still, and this is 8-year-old material, even though for a while smoking was down, we're starting to see a mini uptick again. Don't know why. It was down to it went from, over the time I've been teaching, it's probably from 25% down to about 14% of people who smoke, and principally smoking cigarettes. Now, it doesn't preclude other types when they say they're a smoker, and then raising it up. And you'll find for many of you, when you get out into the working world, my son down in Florida, he just signed on with a new company. The big thing was they asked him specifically over time for smoking. That had to do with how much they were going to take out of his check for health insurance. That was the biggest single factor. They weren't asking about any other thing. They're asking about smoking. Cigarettes, pipe, anything else. So that's the big problem. So the most common types are typically glandular. The great majority, these are glands that are typically in the air. It's funny, this is sort of the differential. for smoking. So if we look lung-wise, if you look at this kind of like a sort of bell shape, you got a lung here and a lung here. You see, we will very often see things, and they would call them coin lesions because they're quite a coin shape. And typically they would have calcification, little flecks of calcium. That was typically what you would look for, coin lesions and calcification. The differential between that and tuberculosis is you didn't quite see, the tuberculosis ones wouldn't calcify. They were clusters of cells called giant cells. So they'd have, tuberculosis lives in a macrophage, and then your body, once it realizes there's a macrophage with a bad guy growing into it, they surround it by other white blood cells. It's called a giant cell or a granuloma. And then over time, to a late stage, it begins to calcify and harden. So there's a subtle difference. And a lot of times we would see changes and you would be able to distinguish between them. And so sometimes you'll see it. Now, if it really is very, very obstructive, we'll even see it inside the bronchi. That's squamous cell, rises in the bronchial epithelium, so inside the bronchi. That'll be a bit more centrally placed. The one you do not, I mean, this is the most common. Okay, this is the one you do not want to have. This is called small cell, also known as OAT, O-A-T cell. I think it gets that because when they look at the cancer, it's kind of like an oatmeal-y kind of appearance, I guess, without being disgusting to talk about that. Lymph cells in the primary bronchi that metastasize. That is a very, very poor prognosis. When we talk about cancers, we talk about 5-year survival rates. So probably the 5-year survival rate for these is still well under 50%, meaning from when it's identified and you have a biopsy or a bronchoscopy and they take a section, they go, oop, bad news, this is lung cancer. Half people are dead within 5 years, more than half. It's very, very scary. So and that's the one that has the worst prognosis. None of these are a good diagnosis, but you can survive longer, probably up here with more treatments. And it's a matter of, again, when you're dealing with something like this, inevitably the fatality is there. The thing is, how long can you enjoy a quality of life and for how many years? That's the sad part. And I'll say it again and again. The only reason I'm here and giving you this talk is the wonderful woman I'm married to. I wouldn't know. I would have smoked. On June 20th, everybody, will be 18 years. I've resisted temptation. My son and his best man and best friend, now they're a big deal when they were on the ship or when they were out playing. Hey, Dad, we got these great cigars. They probably got Cuban cigars. Well, come on, you want to have one? No. Because I never want to take the chance of inhaling anything because it was too hard to deal with. So early detection, number one for all cancers, particularly if metastases have not occurred. Now they're able to, rather than remove entire lungs, they're taking small segments and then the appropriate, and thankfully there's treatments. I don't know a lot about sleep apnea. Okay. I used to think I had it. I don't really think I do. That is there. It's very hard. It's almost like whoever your significant other is more likely to become aware of it. Because a lot of times it's waking you up and it's like, I can't breathe. And there are a lot of treatments today. I'm very unfamiliar with it, nor would I ask you about it, that are there. So whether it is the fact that you're not sleeping well, obviously, worse accidents, not necessarily in the vehicle, but at the workplace, different kinds of chronic illnesses, different kinds of devices are available. And that concludes respiratory and concludes today's presentation. Thank you very much for trying to laugh occasionally. And we are done.